that this webinar is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services. And so the contents are mine and do not necessarily reflect the official views of these organizations. So with that aside, let's jump into what we are going to talk about today. So our agenda is that we will start by talking about what distressed rural hospitals have in common. So there's been a lot of academic research on what kind of is associated with distress in rural hospitals. So we'll talk about some of those factors. We will also talk about what happens. So the ultimate consequence of financial distress for a hospital is ultimately that it may close. And so if that does happen, obviously there are lots of consequences for the hospital, the staff, the community. So we're going to touch on some of those, what we've seen in some of the closures that have happened around the U.S. And I'll talk a little bit about some closer to home for me. And then finally, we'll wrap up and talk about some possible solutions. Now, these solutions are going to be, some of them are going to be on kind of the individual hospital level. What can you as an administrator at your hospital do? And then some of these are going to be big picture policy solutions. So that's kind of where we're headed. Okay, so let's start with kind of the big picture. So if you'll go to the big picture slide. So kind of the big picture of what's going on. So there's been a lot of press. There's been a lot of press on what is going on with rural hospital closures. So numbers, and you can see this on really anywhere you look. It's in the media, even on the Archie website. There's lots of information about the fact that hospitals are closing, rural hospitals are closing in record numbers. And a lot of this is, this distress that we're seeing is from declining profitability. And the big driver of declining profitability is declining admissions. So the first thing we've got to talk about is why are admissions going down? First and foremost, admissions are going down because rural populations are declining. And so that's sort of a thank you, Captain Obvious thing, but that's something that we've got to think about. The big picture here is that the needs of these populations are changing and the populations are declining, so that's going to change the kind of care that needs to be provided. Similarly, certain types of care are being provided in larger hospitals instead of in smaller rural hospitals. And again, that's kind of a fact of life that we've got to cope with. And also certain procedures, surgical procedures and so on, have shifted from an inpatient setting provision to more of an outpatient setting, which is not always feasible for rural hospitals with different structures. So what this means for hospitals is that if you have the same level of fixed costs but fewer patients, you're going to have higher per patient costs, and it's going to be very hard to turn a profit. And this is particularly problematic for smaller hospitals because the bottom line is there's certain fixed costs that it takes to run a hospital, whether you have 5 beds, 50 beds, 200 beds. So there's certain fixed costs that are going to be in place that can't change. And so these larger hospitals have more patients to cover them, but smaller rural hospitals don't, and that's going to put rural hospitals sort of behind the 8 ball on that. And all of this is compounded by the fact that certain states haven't expanded Medicaid, and if you're in one of those states, I'm sure you feel that. Although closures happen even in states where Medicaid was expanded. And there's also recently been cuts and threats to cut disproportionate share payments and other rural reimbursement programs, and we'll touch more on that at the end of the presentation. So let's start off by talking about what do we know about distressed rural hospitals. So this is coming from the academic research, and what we see on this next slide, you see that the big blue bubble, we know that financial distress obviously is associated with poor financial performance. But financial performance is kind of hard to measure. There's lots of different ways to look at it. So what I've listed here are some of the key measures of financial performance you want to be looking at. One is profitability. Again, this is sort of an obvious one. If you're turning a profit, that's good. If you're having trouble turning a profit, and this is especially if we're looking at operating margin, that's obviously going to be problematic. Cash flow is also really, really critical. So most of the hospitals that were in financial distress had very low cash flow or even negative cash flow. So that was an issue that we saw. And related to that, if you don't have cash flow, you can't reinvest in your facilities. So we saw a decrease in reinvestment was a very big indicator that financial struggle was on the way. So if you're having trouble generating enough cash to reinvest in your facilities, that's a bad sign. Another issue or another important ratio to look at is your current ratio, which if you're not familiar with what that means, when I say current ratio, that's your current assets compared to your current liabilities. So how many times could you pay off your current liabilities with your current assets? Current assets are things like cash, inventory, accounts receivable. Current liabilities would be things like payables, short-term, things you've got to pay off within 1 year. And also more debt tends to be associated with poor financial performance, although that's a complicated relationship because obviously sometimes debt is necessary to be able to grow and offer the services you need to provide. So that's complicated, but typically speaking, more debt was associated with worse performance. There were also some other characteristics of the hospital that were associated with the probability of being in financial hot water. One would be smaller size. Now, the research all looks at revenues, not beds for this, because beds can be kind of confounded in a lot of the critical access hospitals where maybe they have 25 beds, but their census is 5, their average daily census is 5. So smaller size in terms of revenues. If you're bringing in less net patient revenue, you have fewer patients, you're more likely to be in distress. Goes back to covering those fixed costs we were talking about earlier. Case mix. So surgery is typically the more surgery the hospital provides, the more profitable it tends to be in the rural setting. So that's something to consider, and we'll touch on this as a strategy later. Should we offer more surgical lines? Should we try to drive up those surgical volumes? There's pros and cons to that. But also payer mix. So if you've got more Medicare and Medicaid patients, especially if you're not a critical access hospital, that's going to be tough for you to cover your costs, and so you're more likely to be in financial distress. Older facilities is also a predictor of financial distress, and I think this goes back to that reinvestment thing we talked about earlier. If you don't have the cash to reinvest in your facilities, that's A, not a good sign, and B, going to make it harder to bring patients in and, encourage morale for staff, increase patient confidence, so on and so forth. So older facilities were also associated with being in financial distress. And interestingly, and the research didn't exactly figure out why this was the case, but for-profit rural hospitals tended to struggle a little bit more financially than not-for-profit. And that could be maybe the not-for-profits are able to get more grants or more help from local government or something along those lines. But for-profit status is actually associated with being in financial distress. So going to a for-profit model may not be a good solution if that's one way you were looking at to get out of financial trouble. Probably not the way you want to go. Okay, so moving on. So let's talk about, we talked about things that the hospitals that are in hot water have in common, but there are also things that the communities that they're in have in common. So we'll get to the picture in a second. Let's just start at the top of the list. So more competition in the service area. This was a biggie. So if you are a small rural hospital and the neighboring town also has a hospital, you're more likely to be in distress. There may not be enough patients, a big enough catchment area for you to drive up the volumes enough to be able to do well. So if you have more competition in your service area, that tends to be not an ideal situation for profitability. Also lower population. Again, if you don't have a lot of population in the area, that's going to make it difficult to get the volumes that you need to cover your fixed costs. And also the demographic characteristics of the area. So if you've got high poverty, high unemployment, that's going to lead to either more government payers and or more charity care, and so that's going to be tough on your bottom line. Same thing, higher percentage of Black and Hispanic residents and located in the southern U.S. These have also been shown to be associated with hospital closure and financial distress. Now, a big one, and this is the one you see on the map on the right side, is that a huge driver of whether or not hospitals actually end up closing is if they are in a state that has or has not expanded Medicaid. So on that graph, all of the little buildings in the states represent hospitals closed. I think it was from 2010 to 2014, maybe. And if you'll notice that most of them were in states that did not expand Medicaid. Not all of them, but some of them were, or most of them were. So that's definitely a driver, and I'm sure you, as an administrator, feel that if you're in one of those states. And then finally, if your community has recently lost a key employer or industry, that's also a huge predictor of closure or financial distress for a hospital, because you're losing patients in general. You're a lot of times losing some of those more profitable patients, if you will, the ones with third-party commercial insurance. And so that's also can be a tough sign for a hospital in a community with something like that that's happened. Okay, so those are the things we know are associated with closure now, or financial distress. And then obviously the ultimate consequence of financial distress is closure. And so let's see what we know about what happens when a hospital actually closes. So obviously there's going to be decreased access to care. Specifically, you're going to lose access to specialty physicians, your testing, obstetrics, emergency care. So that's kind of a clear consequence of closure. Also, this has reduced, so basically most of this comes from some case studies of about 7 hospitals that closed around the U.S., and this is what people said were the biggest consequences from that closure. So this also reduced access to primary care, because in a lot of these communities, the ER was used for primary care, a culture of overutilization, because that's just the way that their health system in their community had been set up. So when the hospital closed, primary care closed as well. And then also this created a lack of emergency care for addiction and mental health, because ERs are frequently used for these services, especially in rural communities that lack other resources. And obviously there's also transportation issues. So in a hospital about an hour from where I live, it's in the process of closing right now, and patients will have to travel 37 miles to the nearest hospital if this hospital does indeed close, and it's looking like it's going to. But in general, around the U.S., people are having to travel 5 to 30 more miles to receive care, which this is increasing the burden on patients, but it's increasing the burden on EMS as well. And so this is increasing the cost for communities to provide EMS services. Also, this is a huge issue, is patients finding transportation home after discharge. Maybe they got to the hospital in the ambulance, but the ambulance is not taking them home, and that's a problem if they're 37 miles from their house. And this is especially problematic for vulnerable populations like the elderly or disabled or those in poverty. So the last major theme that people in these areas stated was that this was an economic loss to the entire area. So the job losses for the employees, but it's also the prestige and the identity of the town itself was tied up in the success of the hospital, and that was lost, and that was hard for the community as a whole. And it also made it hard to attract new employers. Having a hospital makes employers more likely to locate nearby. Another hospital, so 2 hospitals in the vicinity around me have closed in the last, I think it's probably the last 6 months or so. And one of them, a major employer had recently left the area, and so the population went down, the amount of insured went down, and so they were not able to keep the hospital afloat, and now they're having trouble attracting new employers to come back and drive that population back up. So one ray of hope is that there are alternatives to complete closure, and some of these hospitals, instead of closing entirely, changed to some other form of care provision. So in this particular study where this table comes from, they looked at 47 rural hospital closures between 2010 and 2014. 26 of them closed, but 21 converted to some other form of care, either urgent care or an emergency facility, skilled nursing or rehab, or an outpatient primary care type facility. So half of the converted facilities went to some sort of urgent or emergent care model. And so this would be anywhere from 24 hours a day down to 12 hours a day, but this left the testing services in the community and some access to outpatient and specialty services, so met that need in the community. Others converted to some kind of skilled nursing or rehab facility, And this may have been, obviously, what model they converted to is probably based on, hopefully, the needs of the community and also the capacity that they had in terms of staff and equipment. And then some converted to an outpatient or primary care type of facility that had some of those services and maybe some urgent care in addition. So this is, in an ideal world, if a hospital has to close, it can convert to some other care model, but there are major barriers to being able to do this. First of all, it's easier for hospitals that have positive cash flow, but if you don't have any cash to make this conversion, it's going to be really hard to make that happen. And a lot of hospitals close because they don't have the cash to remain open. So, keeping up with that cash flow, if this is something that may be in the future of your facility, keeping up with cash flow is going to be critical to make this an option. And with current hospital, so if you convert to one of these models, you're no longer eligible for hospital reimbursement rates from Medicare and Medicaid. And so in an example, I was speaking with the CFO at a hospital system here in town, and they're closing a hospital in their system in a nearby town because there's not enough volume. They were considering converting from an inpatient hospital to an ER, but when they did the projections, it was just more than upside down. It was completely backwards. There was no way for them to be viable to convert from an inpatient hospital to an ER at the rates that they were going to be able to get. And so they would need something like 25 patients in the ER each day, and they could realistically only expect 10 to 15 to cover their overhead costs. So, converting to another model of care would be ideal for many rural settings, but that's going to not feasible under the current system. And we'll talk about some things on the horizon related to that on a policy level a little bit later in the webinar. All right, so that brings us to the solutions and suggestions. What can we do about all of this? And so I'm going to throw a lot of different ideas at you here. Some of them are going to be things that you can implement at your individual hospital level, and some of them are more, these are some big picture policy things that are on the horizon that may affect you or be something you want to look into going forward. So what can we do? If your hospital is in crisis, in financial crisis, you got a couple things you can do. Basically, you've got to get out of the red. And so you can do that by increasing your revenues or decreasing your costs. So to increase your revenues, one option would be to bring in more patients. Well, in an area with a fixed population, like a rural area, and particularly a declining population, one of the only ways to do this would be to add service lines. And so one example would be to add hip and knee replacements at your hospital or something along those lines. Obviously, there's going to be costs associated with that. And the big picture is, even if you can offer more hips and knees at your hospital, studies show very definitively that volume is associated with better quality with surgical care. So if you're only doing a couple of hip and knee replacements a year, the quality of the care and the like is probably not going to be, you're just not going to be able to offer the same kind of volume that's going to give you those economies of scale, and the surgeons who do this every single day, that's just not feasible. That's not possible in a rural setting. So we've got to be really careful when we think about adding service lines. We can't just add it just to drum up the bottom line. It's got to be something that matches the needs of your community. So that's got to be first and foremost in your mind, because it's just really the bottom line is adding those services is kind of maybe not contributing to population health as a whole, but it's also, it's almost just prolonging the agony a little bit. Another option would be to get more reimbursement per patient. Obviously, wouldn't that be nice if we could just decide we wanted to get more reimbursement per patient? But, really to be able to do that, you've got to be able to have increased negotiating power with some of your third-party commercial payers. And one strategy for doing that would be networking and working with other hospitals in nearby regions with similar situations. And we'll touch on that solution a little bit later. But again, getting more reimbursement per patient could just be kind of a Band-Aid on a gaping wound. So that may not really be a strategy that makes sense. So if you, increasing revenues is one option, decreasing costs is another option. And so one way to decrease costs would be to become a little bit more lean. And so I've got a link there that you see on the site, and if lean is something that you haven't looked into for your hospital, I would really recommend that you do. This link is a guide to implementing lean at a rural hospital. So the huge hospital-wide rollouts of lean that you see at these giant urban facilities, that's not going to be possible or even doesn't even make sense at a hospital with smaller in terms of patient size and staff and all of that. But that doesn't mean the concept of going lean can't help your hospital operate closer to or in a more profitable way. So so I'd really recommend that you kind of start here. If you haven't read this, I would really recommend it. It's a 9-step roadmap for implementing lean in rural hospitals. And so some of the things that they recommend is, the first thing is they say, get an internal champion. So maybe that's you. You're listening to this webinar right now. You're interested in it. Get an internal champion, someone who's interested in implementing it, and have that person, rather than having a consultant come out and train everyone to be lean, have this person get that training. Some of the ways that a person could get that training one-on-one would be consider partnering with a larger regional health system. I know I think it was in this article actually, someone that they interviewed, a nearby larger hospital was implementing lean at their hospital and allowed this person to sit in on all the trainings for free because they were already doing it. So see if you can find a partner who's already doing that you can kind of just piggyback on. Also consider banding together with other hospitals in your region, other rural hospitals in your region, and using some of your rural health state funding to get this training all together. It could be a way to kind of cut the costs. It's not just you, but if it's multiple people, it would kind of dilute that cost a little bit. And once the internal champion, whoever that is, learns some of the lean processes, that person can train the rest of the staff. So you don't have to do the whole staff training. It could just be one person. Another thing, when people, especially employees, hear lean, they get nervous and they automatically think layoffs. And there's a way to do lean without doing layoffs. And so I would recommend that is maybe your hospital needs layoffs and that's a separate issue, but if you just want to implement lean, implement it, but when you train the employees, have a no layoff policy. Say, hey, we want to do this, we want to reduce waste, we want to be more lean and more efficient, but we're not trying to lay you off here. So let's all buy into this together, and let's figure out what we can cut elsewhere so we can all do our jobs and do them better. Also, a key part of lean is figuring out what metrics you need to be looking at. What metrics determine whether or not your hospital is operating successfully, however you define successfully. So have your senior staff meet together to develop those metrics and figure out how you can design a system to track that data. That's a key part of lean, is just keeping track of your data, and so that's going to be something that you've got to focus on when you're implementing it. And then finally, and this is something I think you could implement even if you're not doing a full lean rollout, is doing daily huddles for the different teams. So have your administrative staff meet once a day at a certain time for 10 minutes to touch base on things. And same thing for all your clinical staff, whatever team they're on. Make sure that you're having people meet together, and you're going to see some redundancies. You're going to see some places you can cut costs, and that's really where you're going to make the leaps and bounds in reducing costs, reducing waste without hurting patient care or staff morale or things like that. Now, these are some of the ways to increase revenues and decrease costs, kind of big picture. But the bottom line is rural hospitals are in distress because the equation's not really working as it stands right now. So things are going to need to change for rural healthcare to be more financially viable. So I will, in a few slides, talk about some ways to change that equation. One is global budgeting, which is really promising and interesting. And so if you haven't looked into that, that's something that I hope you'll take away from this webinar. And then also some policy changes. So I'll talk about some policies that either have changed or are on the, I guess are at least being introduced in the House and the Senate that may affect rural care provision going forward. All right, so where I want to start when I'm talking about really specific suggestions for an individual hospital are these hospital finance best practices. And before I get into them, I've got to give credit where credit's due. So the source that you see on the bottom of this slide, the Critical Access Hospital Finance 101 manual from ruralcenter.org, is a great resource. If you've never looked at it, they have an updated one that's just come out. I think it just, maybe in 2019, maybe it was in 2018, but very recently. And they go through what are the different kinds of Medicare, Medicaid reimbursement, down to here are the financial ratios that you need to be looking at, here's how you calculate them, here's what they mean, and they also give resources for benchmarking. But part of this manual that you see that I'm referring to came from a meeting of some CFOs of rural hospitals who met together and said, okay, what are the best practices that are critical for hospital financial success? And that's the list that you see here. So their first suggestion was that you have an outside party review your cost report, charge master, and revenue cycle annually. Have someone else come in and look at all these things and figure out what you can do better. So your cost report, you may produce that internally or you may outsource that, but either way, A, you need to know what's going on in your cost report. Your Medicare and Medicaid reimbursements come from your cost report. So if your cost report's wrong and you're underreporting things, you are leaving money on the table. So you've got to make sure that cost report is accurate and correct. So to do that, you need to know what's going on. You know your organization better than anyone else, and so you need to understand what's going on in the cost report, and you need to make sure it's accurate to what's going on in your organization. And it's also going to be a great idea to have an expert come in. There are consulting firms who can do this, who can come in and look at your cost report and say, hey, have you thought about this? This looks a little funny. Maybe you should include this, so on and so forth. And that can really make a difference in your reimbursement. Same thing with your charge master. You're charging based on your charge master, and if your charge master is outdated or not correct in some way, you may not be charging correctly. So someone needs to come in and take a look at that. And then also revenue cycle. Have someone come in and look at your claims and your billing and your coding and your automation and how long this is all taking. And maybe they can suggest some really easy fixes to bring in that cash a little more quickly and get those claims paid either more fully or just more quickly. So have someone come in and do that, and they recommend that you do that annually. Also, you've got to do strategic financial and operational assessments. And what this really means is you've got to think about, are you doing the things that you need to do to be operating in the community that you're in? Do your service lines make sense? Which ones are being utilized? Which ones aren't? Which ones are working? Which ones aren't? You need to make sure that if you figure out what you need to do and you figure out, are you putting your money where you need to put your money? Are you matching your financial resources to the service lines that make sense? And is your hospital running to make these service lines make sense? You've really got to think about, what are my most important service lines to the community and to my bottom line, and am I supporting those? Am I putting my resources toward them? Revenue cycle management, really, we just touched on that. Have someone review it, and then make sure you are implementing those best practices for revenue cycle management. There are, I'll touch on this a little bit later, but at this ruralcenter.org website, there are full trainings, webinars on revenue cycle management for rural hospitals, and so they're free. You can go on and take a look, and they go through revenue cycle management for a rural hospital. And so I would really recommend that you take advantage of some of those resources. Also, because so many hospitals employ physicians now, you've really got to make sure and do some practice management assessments. I know physicians don't always like being assessed, and that can be a little bit tricky, but it's really important to make sure that physicians are doing what they need to do to be supporting your organization if you're employing them. So make sure you look at those contracts, look at those, at what they're doing, make sure that their referral patterns and everything makes sense for your organization. Lean, we've already talked about that one, so I'm not going to beat a dead horse, but consider implementing some version of Lean at your hospital to cut some of those costs. Also, so financial education, and this one is really important. So I think it's from what I hear anecdotally, it can be hard to get financially literate people on your board and even just able working under you. It's important that everyone that touches the finances in a hospital has some level of financial education. And this doesn't have to be a college degree by any stretch of the imagination. But the same website, that ruralcenter.org website, they have some really great resources for board members and managers to just get some idea of how finances work, some basics of accounting. And so I'd really recommend that you get everybody as literate as you can on some of these issues so that they're likely to see, hey, this is an issue, this is not. They'll understand what profit margin and current ratio and things like that mean, and maybe they'll have some suggestions, even if they don't touch the finances on a day-to-day basis. Also, small rural hospital improvement program dollars from your state. We touched on this when we talked about the lean stuff. Pool those together to pay for training, to get the training that you need in lean or in anything else, revenue cycle management, what have you. Work together with other hospitals to get those resources that you need. And similarly, developing CFO networks. So this list that you're looking at came from a meeting of CFOs of rural hospitals. What works at one rural hospital very well may work at another. So figure out a way to link up with CFOs of hospitals nearby to talk about best practices, to talk about some of the issues, to talk about innovative solutions that are working. I know that the CFO that I spoke to, he was a CFO of a larger hospital here in town, but he works with a lot of smaller hospitals as well. And he was saying that he, just from a systems perspective, he would like to meet with other CFOs of systems with rural hospitals to meet together, because I think there's a lot to be learned there from other people who are kind of boots on the ground. So try to take advantage of those networks to the extent that you have them and develop them to the extent that you don't. And then the last one, and we're going to talk about this more on the next slide, is benchmarking. So benchmarking is really important to figure out where you stand relative to your peers. So on the next slide, I've got some specifics on benchmarking. What you see here on the right side, these are some benchmarks for financial ratios for critical access hospitals. So this is just critical access hospitals. These are going to be different for non-critical access hospitals because they've got a different reimbursement scheme. But if you are a critical access hospital, I would really recommend that you use the flexmonitoring.org site. They've got benchmarks by state, and they've got lots of really detailed benchmarks as well. And so you can go and see how your hospital is comparing to other peer hospitals to figure out maybe where you can target for improvement. There's tons of information there on that flexmonitoring.org site. So I'll go through some of these in case you're not familiar with them. Days in net and gross accounts receivable. So basically this number, the 51.34 that you see, that's the median value for all critical access hospitals in the United States in 2016. And it's basically saying that it took the median collection time from point of sale to collection of AR was 51 days for net AR, and 48 is, or I guess that's really 49, rounds to 49 for gross AR. The lower, the better. The lower that number is, the sooner you're turning your accounts receivable into cash. Days cash on hand, 77 days. That means if you didn't bring in any more cash based on the amount you have right now, you could operate for 77 days. And also, I forgot to mention this, these are not picked at random. So these ratios that you see are based on that same group of hospital CFOs that gave the top 10 suggestions on the previous slide. These are the benchmarks they came up with as most important. So these are the things you need to be looking at to figure out if your hospital is healthy. AR is huge because we've got to convert those receivables to cash. Cash on hand, again, a lot of this is going to come back to cash. Cash is critical for any organization, but especially for a rural hospital. Total margin and operating margin, so this is basically revenues minus expenses, either operating or total. Debt service coverage is if you had to pay, how many times using your operating income, how many times could you pay off your debt costs for this year? So that's your interest, any payments that you're making, so on and so forth. So how many times could you pay those costs with your current operating income? And you want that to be as high, the higher is better on that one. Another key one is salaries to net patient revenue. So care provision is a hugely people-oriented service, right? And people are a huge part of the cost of providing health care as well. And that's a cost that we've really got to keep an eye on. So salaries to net patient revenue is, the median value is about 44.9%. Lower tends to be better on that because you have other, you have income or cash available to pay off either to reinvest into your facilities or to make lease payments or whatever. So salaries to net patient revenue, you've either got to, if that's higher than 45%, you've got to think about, is it because my salaries are too high or is my net patient revenue too low? It may be that you're overstaffed for the care that you're providing if that is really, really high. In Medicare inpatient care mix, now technically they say that you want this to be lower, but really for a critical access hospital, that's debatable because those Medicare patients, as we'll talk about in just a minute, are cost-based reimbursement, and that's money in the door. So we'll touch on that one a little bit later. But you do want to look at your total payer mix. How much Medicaid do you have? How much do you have in terms of charity care? You've really got to take a look at that and benchmark that against your other peers in your critical access care group. And then your average age of plant. As we going way back to the beginning of the webinar, an older plant is associated with plant meaning facilities. Older facilities are associated with more financial distress. You've got to be able to keep up with those facilities, make sure things are new and feel safe and comfortable for patients to be able to continue to bring in those patients. And then long-term debt to capitalization or debt to equity. So generally, we want less debt financing because that puts us under less pressure, although debt is not always bad. And if you are interested in knowing more about these ratios, again, downloading that critical access manual that I referenced on the previous page, they have just pages and pages talking about how to calculate each of these, what they mean, and even in some cases, some solutions for, I think there's actually on that Flex monitoring site, there is a webinar of some of these benchmarks and then some possible solutions and suggestions. So I would, again, point you to that if that's something that you are interested in and think would be helpful for your organization. Okay, so moving on. So this is something I touched on just a few minutes ago, but if you are a critical access hospital, you need to maximize your cost-based reimbursement. And so I want to spend a few minutes. You probably already know this, but in case you don't know it or don't fully understand it, let's talk about what cost-based reimbursement means. So Medicare in general, Medicare and Medicaid, pay on a prospective payment system, which provides a fixed amount based on a patient's diagnosis. So so-and-so has pneumonia, you get this amount. So now cost-based reimbursement is different. Cost-based reimbursement reimburses a hospital for allowable costs from their cost report. So that means no matter what the patient's diagnosis is, you get paid cost for their care. So basically, you can't lose money on those patients. This is, again, only available to critical access hospitals, and allowable cost is pretty broad, all patient care expenses, salaries, depreciation, and so on, as well as other costs like sales taxes and property taxes, and different fees, recruiting expenses. So basically, if we're talking about how to calculate cost-based reimbursement, let's take an example. ABC Hospital is critical access, and they report $5 million of expenses on their statement of operations in their Medicare cost report. And remember, this all comes back to that Medicare cost report, and that's why you've got to make sure this cost report is right. 65% of the patients are Medicare, and the remaining 35% are third-party payer. Which wouldn't that be great if that was everyone's mix? But let's just, for the sake of simplicity, let's say that's what it is. So reimbursement from CMS would be $5 million in operating costs times 65%. So you would get reimbursed $3.25 million from CMS. Now, if the remaining 35% of your patients don't bring in the rest of the reimbursement, you're going to have a loss for this year. So what this tells you is the higher that Medicare percentage is, if you are a critical access hospital, the more of your costs you are definitely going to be able to cover. So it's easy to think that those commercially insured patients are going to be the ones that really turn a profit, but most commercial insurers use some kind of prospective payment system. Now, they may pay more than government payers, but they're still not going to do cost-based reimbursement like Medicare does for critical access hospitals. So if you are critical access, you really need to maximize those revenues coming from cost-based reimbursement. It's critical. The more Medicare patients you have, the easier it's going to be to cover your costs if you're a critical access hospital. Now, this is not true if you're not a critical access hospital. So this is only a special case for critical access hospitals. Okay, so let's move on. Now, this is true for everybody, critical access or not. 340B programs. So these have been in the news in the last couple of years. and under some scrutiny, and some people love them, some people hate them. So 340B was initially passed in 1992, and it basically provides outpatient drugs to eligible hospitals, which rural hospitals are, at discounted rates. And the point is to kind of provide some extra cash for rural hospitals to provide care for uninsured and low-income patients. So these savings are going to kind of pass on to the patients. Now, some of the scrutiny in recent years has come because it looks like some organizations just kind of pad their bottom line with 340B payments and don't really need them. But that's generally not the group of hospitals we're talking about here. Rural hospitals, a lot of times these are a lifeline. I've seen financial statements where 340B payments are the difference between operating at a total loss and operating at total income. So they're very critical for rural hospitals, and you need to make the most of them. And I'll admit, I am not an expert on maximizing your 340B reimbursement. I did cite a website here from someone who is an expert and pulled out some of his key points. So one would be, if you're using a third-party administrator to do this 340B program, you need to automate the transmission of your data. And this is, I think, a point that I've touched on in various ways. Automation is key. I know that can be tricky to get the technology to do that in a rural setting, but if you're not automating the transmission of your data, if you're relying on manual transmission, things are going to get lost. Things are going to get behind. You're not going to get it turned around as quickly. You're not going to get your reimbursement as quickly. So you want to make sure and automate the transmission of that data. You also need to look carefully at that data and make sure it's complete. Only you, as the administrator, will be able to tell if this is a complete picture of drug costs at your hospital. So make sure, don't just blindly turn it over. You need to be reviewing it periodically to make sure it's complete, because if it's not complete, you're going to get less matching. And then let's look at what is matching and what's not. So if there are prescriptions that aren't being matched, either work with your third-party administrator if you're using one, or even talk to the pharmacy that you are working with, because it's in everyone's best interest to get these prescriptions matched. So make sure and take advantage of that and work with the people that you're working at to make sure you figure out which prescriptions are being matched, which ones aren't, and what you can do about that. And again, make sure and take advantage of that website that you see down below for some more specific suggestions. All right, now right sizing. So that's the next topic, and this is kind of maybe one of those dreaded words or something that people don't really like to think about, because right sizing, again, it kind of has that layoff, downsizing, icky connotation. But right sizing, you've got to think about that as not as a bad thing, but as meeting the needs of the community that you're in. So this chart that you see on the right is pointing to what we see here. So a lot of critical access hospitals have 25 beds and a daily census of 3 to 5. That just really doesn't make a ton of sense with the high fixed operating costs of inpatient care. So what you see here, the first graph is an average acute occupancy rate. So you can see the occupancy obviously is higher in urban hospitals, and it's a little lower in rural hospitals, but it's lower in critical access hospital in terms of percentages. And kind of the related graph on the right shows the bed surplus. You can see that the bed surplus is pretty high for critical access hospitals. You've got a lot of extra capability and capacity that you're just not really using to provide care, and so that's not going to be good from a financial perspective. So when you're thinking about what your hospital needs to do, you've got to think about matching your services with your community needs. So that may mean you need to cut some service lines. It may mean that that ideally you'd be able to convert to a different model of care, although there are some issues with that at current reimbursement rates. But even if you don't do any of that, think about telemedicine. So some of the things that you're now providing in-house, could you provide via telemedicine with an expert or a specialist in the field in another community? And one way to do that is, and a critical way to do this, is you've got to develop some kind of partnership with a larger health system. This doesn't mean merging or being owned by a larger health system, but developing a partnership. So when a patient comes in and you don't have, and they're too high acuity and you can't handle them, you can pick up the phone, you know who to call at the regional hospital an hour and a half away, and they can get that patient there ASAP. That's critical. So for providing patient care, that's critical. For getting the services you need for the patients in your community, that's critical. And for just making the most of your facilities and not overstretching yourself, it's critical. They may also have resources they're willing to share to keep low acuity patients closer to home. So really make sure and work on those partnerships, see how you can scratch each other's back, so to speak. And then also, if you do cut down on your capacity, be smart with your extra space. So you can convert this to a medical, maybe a medical supply store, or rent it out for primary care provision, something like that, but just make the most of that extra space. Okay, now networking, we've really just talked about this. So networking is critical. So you could consider joining a larger health system. You could have, this is going to help health record compatibility be better, improve data sharing, which is going to be potentially lower administrative costs for you and better care for the patient. You're also going to get to play into those economies of scale, especially when it comes to things like purchasing. And also, it can allow small rural hospitals to join programs like accountable care organizations and value-based care that are out of their reach at the size that a rural hospital is independently. It's also going to allow equipment sharing for costly or specialized items. And if you have a bad year but you're a part of a system, it's not as big of a deal. So it can kind of buffer the consequences of one bad year of operations. But the bottom line is, if you join a larger health system, you're potentially going to reduce the flexibility to meet your unique rural community needs. So previously, if you have a community need, you just go to your board and they say yes or no, and you can do it. But if you join a system, you've got to go to the system leadership, and they've got to talk about it, and it's going to take 3 weeks, and then da-da-da-da. So it can reduce your flexibility and your ability to meet the needs of your community. Another option is to join or create a hospital network, and so I think this is kind of interesting. So TPC, if you haven't heard of it, is a group, a network of health systems. So it's not one big system, it's 10 health systems with 20 hospitals, 250 individual sites. And basically, they've banded together and gotten some of the economies of scale that would come with merging, but haven't lost their independence and autonomy. So they basically have they have $1 billion in purchasing volume, and they've saved a lot of money with this group-based purchasing that they can do all together. So they've got the group purchase discounts that have saved money. They've also been able to share innovations across in terms of clinical operations and patient care, reduce some overhead and labor costs, and they were able to aggregate their revenue cycle management across all systems. And that's huge. If you don't have to manage that, and if you have larger resources to be able to manage that, you're going to be able to collect faster. You're going to make sure your billing and claims are more accurate, and that's going to be a win all around. So think about if there's something like this nearby that you could join, or think about or developing this. And I'd really recommend, this is a really neat, it seems like a very interesting group. So if it's something you're interested in, I'd recommend that you go look at their website and kind of see what they're doing. All right, so now we're moving on to the more big picture, how can we change the equation, right? Not just little things that we can do to help our hospital survive day to day, but big picture, what can we do about the rural hospital financial crisis? Global budgeting is one technique or one policy that's kind of picking up momentum. So if you aren't familiar with the concept of global budgeting, with a global budget, basically a hospital prospectively negotiates with all payers for a fixed budget for the year. So they talk to government payers, third party, whatever, and they negotiate a fixed budget for the year, and they receive 1/12 of that amount each month. And so basically this is a system where the revenues are fixed. You can't drive up volume by providing more services, and you are rewarded for providing more cost-efficient care. And so the good things about global budgeting is that, at least in theory, it's going to align hospital incentives with population health. The healthier the population that you serve, the lower your costs are going to be, and the more profitable you're going to be. Ideally, it would decrease preventable readmissions without the kind of icky side effects we're hearing of the the current readmission policies that Medicare and Medicaid have. With not readmitting when you should, and so on and so forth. So ideally, it's going to align hospital incentives with patient care, emphasize population health, and there's more incentive to have connections to other community health providers to make sure everyone's kind of in it together to have the community be more healthy. And it also eliminates substandard or underused service lines. There's no point in having them if they're not being used. A huge one is that it's going to reduce the tug of war with payers. So if you have a fixed revenue stream from a payer over the course of the year, you don't have to fight over every single individual patient. And so that's going to eliminate a lot of administrative headaches. And it also gives this hospitals an option of being sustainable without having to drive up volumes or compromise care. So this sounds a little idealistic and pie in the sky, and perhaps it is, but it has been successfully implemented in Maryland at 10 hospitals since 2010. So they've been doing this for almost 10 years, and it's worked well. There's been improved patient outcomes and improved financial condition of the hospitals that have done it. And it's currently being rolled out in Pennsylvania. So Maryland is unique because they have a rate setting authority, so they already had some of the groundwork in place to be able to set this up, but Pennsylvania did not have any of that. So Pennsylvania is kind of the big experiment right now, and Pennsylvania does have a lot of rural hospitals, so it'll be interesting to see as global budgeting is rolled out in Pennsylvania, if it is also a good solution there. But also, you know, this is lots of heady optimism here, but global budgeting, in theory, is supposed to, A, improve the financial conditions of hospitals, and B, reduce the cost to payers. And that would be ideal if we could do that and not compromise patient care, but it sounds a little good to be true, and there may be some unintended consequences of this that have not yet been seen. So global budgeting is definitely something to consider and something to keep your eye on as a rural hospital provider administrator. All right, so some policies that have either recently changed or are on the horizon. So most of you are probably already aware of the changes that have happened. So for a while in the last, I think it was in 2018, low volume hospital programs were kind of potentially going to revert back to previous rates, and it was going to be really bad for rural hospitals. But fortunately, the low volume hospital program has stuck around, and it's now being reimbursed on a sliding scale, so up to 25% reimbursement for low volume hospitals that qualify until 2022. It's safe. And Medicare dependent hospital, the status has also been extended for 5 years until 2022. So those two designations are safe. 340B, as I mentioned earlier, there's also been some changes to that recently. Cuts were made in 2018, but a federal court put an injunction in place, and so there will not be further cuts to the 340B program as far as I can tell. Also, changes to uncompensated care, disproportionate share payments. So this is changing, and this could be a big one. So the CFO of the regional hospital that I was speaking with the other day, this is a big one, and this is in their projections for their small hospitals in their system. This is going to be problematic, and this is going to be hard. And that may not be true for every system, but he did say for their hospitals it was not looking good. So previously, disproportionate share payments were based on how many Medicaid, dual eligible, and disabled patients you have. Now they're moving to a model that's going to be based on charity care and bad debt. So this is going to be hard on hospitals that don't necessarily have a ton of charity care but do have a lot of Medicaid or dual eligible. This is going to be hard for those hospitals. And so this could result in some cuts to your uncompensated care reimbursement from the federal government. So that's definitely something you need to keep an eye on, and you need to look at how that's going to affect your hospital if you haven't already. Also, if your hospital provides some kind of post-acute care, that is moving, so CMS is moving to a patient-driven payment model, which is kind of like prospective payment. There's going to be a DRG for patients needing post-acute care. You've got to have a DRG to be able to be reimbursed, because you're going to be, it's not called a DRG, but you've got to have a diagnosis to be able to be reimbursed for post-acute care now. And so it's going to change, it's going to change how the reimbursement happens. There's going to be a big cash flow up front, but not as much down the road. It's not going to be volume-based like it was previously. And also, you've got to have a formal diagnosis for these post-acute patients before you can provide care. And so that's going to drive up the cost. You've got to have, you can't just say, oh, this person probably needs this, that, and the other. You've got to say, okay, this person has this condition and needs this care. And so you've got to have a definitive, whereas you maybe just would run a few tests before, you're going to have to run a lot of tests now and have a therapist actually do a full assessment before you can get reimbursed for that care. So that's going to front load those costs. Now, the reimbursement is also going to be front loaded, but that's something that you need to think about how that's going to affect your organization if you are providing any kind of post-acute care. And then also there have been, so traditionally it was hard for rural hospitals to join accountable care organizations because a lot of the reimbursement in ACO, well, first of all, some were just explicitly excluded low volume hospitals. Some of these ACOs and different policies, different organizations. But also, it's hard to get reimbursed. Like, for example, if your reimbursement is based on something like fall rate, you have 2 patients and 1 falls, well, you have a 50% fall rate, so you're not going to get reimbursed. And so the rules and the reimbursement schemes for ACOs were not friendly to rural hospitals previously, but there have been movements toward developing a model that is a little more friendly. Now, the last thing I want to touch on is some proposed policies that are kind of on the deck in Congress right now. So there are 3 that are all kind of similar. They were they were introduced in 2017 or 2018, and so they're all a little different. Some of them include some kind of financial stabilization, so the Save Rural Hospitals Act, for example, reverses some of the cuts to rural hospitals that have happened in previous years. But what all 3 of these do is they establish some kind of new reimbursement scheme for non-inpatient care. So it would allow, all of these would allow some mechanism by which rural hospitals could convert from an inpatient hospital to some kind of emergency room and outpatient care model. And so at current hospital reimbursement rates. So basically, all of these legislations would potentially make it possible for a hospital to convert to one of these sort of lower acuity, non-inpatient models in a financially viable way. And some of them, Save Rural Hospitals focuses on what are currently critical access hospitals, whereas the other 2 focus on rural hospitals in general, but that's kind of the gist of all of them. Now, they were introduced in 2017 and 2018, and then they kind of just sat there, and not a lot has happened on any of them lately. But Senator Grassley, who is the sponsor of the REACH Act that was introduced in the Senate in May 2017 and is kind of a historic champion of rural health, has become chairman of the Senate Finance Committee in 2019. So it'll be really interesting to see if he can start making some movement on some of these acts that would really make providing the right kind of rural health care a viable option for rural hospitals. So these are things that, as you go forward, I think would be really helpful for you to keep your eye on. Some states, Kansas and Oregon, as 2 of them, have kind of done some experiments with this to see if they can do some kind of ED outpatient model that's financially viable. So that's, if this is something you're interested in, I would recommend that you take a look at those 2 states and what they've done. So that brings my presentation to a close. Here are some of my sources. I really hope that you enjoyed this and got something out of this that can make your hospital a healthier place to be going forward. Thank you.
Thanks, Kayla. That was really informative, and we will open it up for questions now. If you have a question, feel free to type it into the chat box, either to everyone or privately. We do have a couple of questions in the private chat. Someone requested the links, and we will make those links available to you. After the presentation, we'll send out a survey, and if you would take just a moment, it's truly just a 60-second survey just to let us know what you thought and then what you would like to see in future webinars. So if you'll just take a minute to fill that out, the links will be in that survey email. And then you can also catch a replay of the presentation on our website and our YouTube channel, and those links will be in the survey email as well. The other question we got was, how can gross days be lower than net days?
Gross days, this is on the benchmarking. Let's go back and see. Gross days, that's a good question. I haven't looked into this data specifically, so off the cuff, I can't tell you exactly why it is that way, but this is where I would say you can actually see this data I think this comes from that Critical Access Hospital manual, and so I'm guessing that they talk about that in more detail here, and since I didn't prepare the numbers, I don't want to say the wrong thing and tell you the wrong answer. So I would refer you back to that Critical Access Finance manual. I think that you could see this actual information and the people that actually calculated it talk about it there. So I would probably refer you to that to be able to answer that question correctly. But yes, that is funny.
Great, thanks, Kayla. And do we have any other questions? And again, we will make the presentation available. I saw another question about that. You will have access to it. Okay, I don't see any other questions, but if you think of something, please feel free to shoot us an email, go to our website, or respond to one of the emails that you get following this webinar. Thanks again, Kayla, and we thank you all for joining us. Have a wonderful afternoon.